Hi guys, let's see about developmental dysplasia of hip. It is a spontaneous subluxation of the femoral head. It was previously called as congenital dislocation of the hip, even though it can present after birth. Pathology is flat or shallow acetabulum which causes the head to dislocate. Other causes include laxity of the fibrous joint capsule. It is more common in female child, firstborn child, fetal malposition like breech, family history of DDH is usually present. It is more common on the left side and it is more common in fair, that is Caucasian population, due to the swaddling of the baby. Clinical features: limb shortening can be seen, increased thigh and gluteal folds can be seen, and limitation of the abduction of the hip is also usually seen. On examination, we can have vascular sign of Narat, which is usually we palpate the pulse against a bony prominence. In this case, the femoral head is not present in its usual position, hence the femoral pulse is not palpable, even though the popliteal pulses can be palpable. This is called as vascular sign of Narat. Less than 3 months of age, we can perform Barlow's test and Ortolani's test. In Barlow's test, we adduct the hip of the baby to dislocate the hip. So we can remember it as bad provocative test. So B for Barlow, A for adduction. It is a provocative test. We are dislocating the head. Other test is Ortolani's test. It is the opposite of Barlow. Here we abduct the hip of the baby. Both Barlow's and Ortolani's test must be performed on each hip separately. And limitation of abduction of the hip is also seen. In Ali's or Gagliardi sign, both the patient is made to lie down and flexion of the hip and knee is performed. The affected knee will be at a lower level. Trendelenburg gait is seen in walking children with unilateral developmental dysplasia of hip. And in Killisik test and Warling gait are present in bilateral DDH. In X-ray, we have two lines, which is Hilgen-Reiner's line and Perkins line. Hilgen-Reiner line is a line; it's a horizontal line drawn through the triradiate cartilage of both sides, and Perkins line is a line perpendicular to the Hilgen-Reiner's line and which passes through the lateral edge of the lateral margin of the acetabular cavity. Usually, a normal femoral head is present in the lower inner quadrant of this picture, but in developmental dysplasia of hip, it is present in the upper outer quadrant. And the treatment for developmental dysplasia of hip is classified according to age wise. For first 6 months, we can use Pavlik harness or von Rosen splint. In 6 to 18 months, we can do either open reduction or closed reduction followed by hip spike off for 3 months. And in 18 to 36 months, we can do femoral osteotomy, and in more than